Hello and welcome to ISGyP Live Journal Club for July 2024. This month's topic is ovarian and fallopian tube epithelial neoplasms. My name's Rohan Larry. I'm coming to you live today from Marda Pathology in Brisbane, Australia, on the traditional lands of the Jagera and Turrbal people. And with me today are my fellow moderators, Dr. Xian Chen and Dr. Deborah Smith. Now, Journal Club alternates between the two hemispheres. You're listening to the Eastern Journal Club. We go out at 10 a.m. Singapore time on the third Thursday of each month. And the other hemisphere, which, sorry, I've misspoken, is the Western Hemisphere, goes out on the third Wednesday of each month. August will come to you from our colleagues in the Western Hemisphere with the topic of vulva and vagina. Now, ISGyP is really keen to engage trainees and early career pathologists. We invite anyone listening today to apply to become a Journal Club presenter. You can contact me, my email address is on your screen, or in Western Hemisphere, Natalie Benet. There's also the Interesting Case Presentation Series, coordinated by Doctors Pinto and Wadi, which gives trainees chances to present interesting cases in which they've been involved. The learning objective for Journal Club is to engage trainees in reading and critically assessing the current literature and to develop their presentation and analytical skills. So each presenter is partnered with a mentor, one of our moderators, and we support that presenter through the reading and analysing the article allocated to them and developing their presentation with a template that we supply, so there's a standardised framework. Our aim is to make it an enjoyable, educational and well-supported experience for all of our participants. Now, ISGyP offer a wide range of educational events and resources online. You can watch these live by registering through ISGyP. ISGyP members also have access to the full archive of slide seminars, lectures, journal clubs and meetings. This is a great resource. It's free for trainees who register with ISGyP, and membership is subsidised for pathologists from developing countries. Coming up through ISGyP Live over the next couple of weeks, there's a couple of events that are really worth noting. Firstly, Dr. Esther Aliva of Mass Gen will be presenting a webinar on mucinous ovarian tumours. That's August 1st. Dr. Ash Chandra from Guy's and St Thomas's in London will be presenting a slide session for cytology in Gynepath. That's August 8th. And one a little bit further off to mark in your diary is the 4th annual meeting. It's entirely virtual, and that's scheduled for September the 28th, 2024. Today's Journal Club is in a webinar format if you're watching live. If you have a question for our presenters about their article, you can submit it via the QA function. We'll hold all the questions to the end, and the panel of moderators and the presenters will discuss today's papers and will feed your questions onto our presenters. There's also a chat function in the webinar live session, so please feel free to say hello, tell us where you are, or if you've got any other questions or comments, you can put them in the chat. So today we have three great speakers with three interesting articles. Our first speaker is Brooke Liang. So Brooke is a gynecological pathology fellow at Stanford University in the United States. Brooke will be talking about Kang et al.'s recent article from the International Journal of Gynepath, TP53, as a diagnostic aid in the distinction of ovarian mucinous borderline tumours from mucinous carcinomas. She'll be followed by Dr. Stephany Ngombu. Stephany is a third-year resident at the University of Chicago. She'll be talking about Smithgall et al.'s recent paper in the International Journal of Gynepath, HER2, ERB2 immunohistochemical expression and copy number status in ovarian mucinous tumours. And our third speaker today, flying the flag for Australasia, is Dr. Tariq Kader from Wellington, New Zealand. So Tariq will be talking about Travaglino et al.'s recent article from Virchows Arch, ovarian endometrioid carcinoma with a sex cord-like pattern, a morphological, immunohistochemical and molecular analysis. That's my introduction job largely done. So I will ask our first speaker to share her screen. So Brooke, can you please share your screen? And thank you.
Right, hey everyone. Again, I'm Brooke Liang. I'm a gynecologic pathology fellow at Stanford, and today I am going to be presenting the article titled TP53 as a diagnostic aid in the distinction of ovarian mucinous borderline tumors from mucinous carcinoma that was published in 2023 and written by Kang et al. Introduction. Distinguishing ovarian mucinous carcinomas from mucinous borderline tumors is challenging. One feature that strongly contributes to this is that architectural complexity, which is required for calling the more common confluent expansile invasion for the diagnosis of carcinoma, exists on a spectrum. And at this point in time, several studies have been published showing that inter-observer and molecular overlap exists between these two categories. This group and others have published that TP53 mutations occur more frequently in mucinous carcinomas than in mucinous borderline tumors, and in fact, TP53 is thought to be implicated in the progression of carcinomas. And so the aim of this paper was to assess whether TP53 IHC could improve inter-observer distinction of mucinous borderline tumors versus mucinous carcinomas. Materials and methods. This was a single institution retrospective review of ovarian mucinous borderline tumors and mucinous carcinomas. The institution searched their archives between 2016 and 2020 and found 85 consecutive cases that fit these categories. If not already performed clinically, one tumor block selected for having the worst area was stained for TP53. Then 3 gynecologic specialty pathologists reviewed 3 representative digital slides per case and provided diagnoses either along a trinary categorization with mucinous borderline tumors with intraepithelial carcinoma, or mucinous carcinomas, and also by binary categorization, just mucinous borderline tumors versus mucinous carcinomas. And these diagnoses happened in 2 rounds. In the first round, there was no information given about TP53. In the second round, pathologists had the opportunity to revise their diagnoses after being given reports of the TP53 IHC status, but without actually being able to review the slides themselves. Moving on to results, inter-observer reproducibility. In the trinary classification, the average kappa coefficient did increase, so reproducibility increased from 0.6 to 0.76 with integration of TP53 IHC data. And by the binary classification, the average kappa coefficient increased from 0.72 to 0.82 with integration of the TP53 IHC data. So Figure 1 illustrates some cases in the different diagnostic boxes in which all the pathologists agreed upon in the first round. So in A and B, there's an example of an ovarian mucinous borderline tumor with low architectural complexity and low nuclear atypia. In C and D, there's a mucinous borderline tumor with intraepithelial carcinoma, in this case showing a less than 5 millimeter focus with glandular complexity and high nuclear atypia. E and F illustrates a mucinous carcinoma with confluent invasion, moderate nuclear atypia, and atypical mitoses. And G and H also shows a mucinous carcinoma, but this time with destructive invasion. So moving on to round 2, so after P53 data was provided to the pathologists, pathologists changed their diagnoses after TP53 IHC results in 9.8% of cases on average. In 80% of instances, the diagnosis was upgraded, and in 20% of instances, the diagnosis was downgraded. The revised diagnoses changed 14 cases that had been discordant into consensus diagnoses, but introduced disagreements in 3 cases that had been consensus diagnoses and made them disagreements. Disagreements among the 3 study pathologists remained in 15 out of 85 cases after TP53 IHC revisions. So they were in round 1 disagreements, and in round 2 there were still disagreements. So what were those cases? The next couple of figures illustrate some of them, and the authors identified 3 general challenges that contributed to these ongoing discrepancies. So one challenge had to do with assessing the degree of luminal irregularity, i.e. labyrinthine or maze-like growth pattern. So in C and D, there's one example of this. Pathologists were split between MBT and MC with no change after TP53, and there was only 5% overexpression in TP53 in this case. And in E and F, pathologists were split between MBT and MC, again with no change after TP53 integration, and this was called a normal P53 result. Per the authors, though, this case actually had sufficient luminal irregularity to be considered a mucinous carcinoma. Another challenge had to do with assessing the degree of intervening stroma/confluent growth. G and H is an example that showed an adenofibromatous background, and this was initially interpreted as majority MBT, and then after TP53 integration, which they were told was 75% overexpressed, it flipped to be a majority MC diagnosis, but there is still some discrepancy, one holdout that said it was MBT. Per the authors, this tumor showed limited remaining intervening stroma and should have been considered a carcinoma. A third challenge had to do with assessing nuclear atypia, and this is most important for the evaluation of intraepithelial carcinoma. So in A and B, there's an example of pathologists being split between MBT and MBT with IEC, and there was no change after TP53 IHC data, which was normal in this case. In C and D, the pathologists were split between MBT and MBT with IEC, and there was again no change after TP53 IHC. In this case, TP53 was overexpressed. Moving on to outcomes. 6 out of 85 patients in their series died of disease. All 6 cases associated with death showed abnormal TP53 staining. 4 out of 6 cases had a consensus diagnosis of carcinoma. However, there were 2 cases where at least one study participant assessed the case as MBT with IEC even after TP53 integration. So the next figure illustrates the 2 cases in which this happened. So one of 2 patients is illustrated here who died of disease without a consensus diagnosis of MC even after TP53. This case was described as having a 3 millimeter focus of invasion with moderate nuclear atypia and other areas with cribiform structures and hyperchromatic nuclei. TP53 was abnormal. One pathologist interpreted the invasive focus as an infiltrative pattern of invasion and therefore classified the case as carcinoma before and after TP53. The second patient is illustrated here. This case was assessed as carcinoma by 2 and borderline with IEC by 1 pathologist without change after the TP53 IHC. There was diffuse nuclear atypia with 100% overexpressed TP53. However, this case was not felt to have unequivocal infiltrative or confluent invasion for calling carcinoma. Clinical pathologic parameters. Using the final majority diagnoses, there were 61% borderline tumors, 7.1% borderline tumors with intraepithelial carcinomas, and 31.8% carcinomas. Borderline tumors with intraepithelial carcinoma cases had smaller tumor size compared to either the borderline tumors or the carcinomas. About half of patients underwent pelvic lymph node dissection, and all lymph nodes across the board were negative. 85.2% of mucinous carcinoma cases showed abnormal TP53 expression compared to 19.2% of mucinous borderline tumors, compatible with the numbers given in the introduction. Average extent of abnormal TP53 overexpression was 60% in mucinous carcinomas compared to 11% in mucinous borderline tumors. Conclusions and discussion. There was moderate inter-observer agreement in the context of ovarian mucinous tumors on morphology initially, kappa statistics 0.60, and this was compatible with prior studies. Then integration of P53 IHC increased consensus diagnosis for mucinous borderline tumor with intraepithelial carcinoma, and mucinous carcinoma by 13%, and improved inter-observer reproducibility to a kappa statistic of 0.76. So the first recommendation by the authors is that ancillary TP53 IHC can be used to provide additional information in cases with features of both MBT and MC. And then there is the important point of TP53 interpretation. In the conclusion section, the authors note that in mucinous carcinomas, generally greater than 40% of tumor cell nuclei showed normal overexpression, whereas in mucinous borderline tumors, less than 30% of tumor cell nuclei showed normal overexpression. They do note that there was an overlap in overexpression of TP53 in MCs versus MBTs, with, for example, the lowest abnormal distribution observed in a carcinoma associated with death being 30%. So the second recommendation by the authors is that reliance on TP53 IHC should be restricted to challenging cases, and that the extent of overexpression should be considered in the interpretation. Of note, this 40 to 30% cutoff for overexpression of TP53 is quite a bit less than what we're used to using conventionally in gyn pathology practice. So some strengths and weaknesses that I pulled from this paper, the main big strength is it provides evidence for a new tool in our arsenal for distinguishing this difficult distinction of mucinous borderline tumors and mucinous carcinomas. A few potential weaknesses. TP53 is not entirely sensitive, as there are TP53 independent mucinous carcinomas, nor is it specific, as some mucinous borderline tumors have abnormal TP53. The study pathologists did not interpret the TP53 stain slides themselves, but were just given overexpression numbers. And then only one block per case was stained for TP53, which we know will not necessarily capture the full heterogeneity of TP53 in a given tumor. That being said, this is what we do in practice, just stain the best block for TP53. So I find that potentially using the data that they derived from just staining one block to be most practicable, most useful in practice. Analysis was performed predominantly on the trinary classification, so including the MBTs with intraepithelial carcinomas, despite how in terms of clinical management, it's really more the binary classification that matters. Is it an MBT regardless of IEC, or is it a carcinoma? The authors point out that they were not able to show improved outcome stratification after TP53 IHC integration, and they said that this was because of low numbers of cause-specific deaths. And so potential weakness, they could have increased their ends by having more study pathologists in more cases, by calling their friends and doing an interinstitutional case instead of just a single institution review. These are my references, and I think we're doing questions at the end, so I will stop sharing now.
Thank you, Brooke. That was very interesting and very thorough. And I can tell you already have a couple of questions floating around in chat, so prepare yourself. But in the meantime, I'll ask Stephany, can you please share your screen? Thank you, Stephany. That's all good.
Can you see the full screen?
Yes, we can.
Okay. Good morning and good evening, everyone. Again, I'm Stephany Ngombu. I'm a third-year pathology resident at the University of Chicago. Tonight, I will be presenting this paper by Dr. Smithgall and colleagues titled HER2 Immunohistochemical Expression and Copy Number Status in Mucinous in Ovarian Mucinous Tumors. This paper was published last year in the International Journal of Gynecological Pathology. Just to give a little background information, mucinous ovarian carcinomas are a rare subtype of ovarian epithelial neoplasms. They account for about 3 to 4% of primary ovarian tumors in North America. They usually arise from mucinous borderline tumors, and they have known molecular changes in KRAS, CDKN2A, and TP53. If you catch this tumor early on, you will usually have a better prognosis, but late-stage tumors have a poorer prognosis and don't respond well to chemotherapy. HER2 status is emerging as a way to classify gyn cancers and can be applied to mucinous ovarian carcinomas in order to broaden therapeutic options. Right now, there aren't any standardized criteria for interpreting HER2 expression for MOCs. So the goal of this paper for the authors was simply to document the IHC patterns of HER2 in primary MOCs and MBTs. And they also wanted to compare IHC protein overexpression with fluorescence and site 2 hybridization gene amplification. This study was a retrospective case review that was done between 2000 and 2020 at Weill Cornell Medical Center. And the authors pulled slides and tissue blocks to be reviewed by 3 gynepathologists independently for consensus. Each case of HER2 was quantified using 2 different protocols, including the gastroesophageal carcinoma and the endometrial serous carcinoma scoring protocol. So I just wanted to highlight the differences between these 2 scoring protocols. The main differences are highlighted in red. For the gastric carcinoma protocol, they use a cutoff of greater than or equal to 10% staining in tumor cells, whereas the endometrial serous carcinoma uses a cutoff of greater than or equal to 30% tumor cells. A score of 3+ for both scoring systems is the same. However, a score of 2+ for the gastric system requires weak to moderate staining in the 10% cutoff, whereas in the endometrial serous carcinoma system, it has 2 options of either complete or basolateral staining in less than 30%, or weak to moderate staining in greater than 10% of the tumor cells. A HER2 DNA probe kit was used to rule out gene amplification, and each case was manually scored using the ASCO/CAP 2018 guidelines that are used for breast carcinomas. The parameters for interpretation included a HER2 CEP17 ratio of greater than 2 and a mean HER2 copy number greater than 20. These next 2 figures come directly from the paper, just to give you an example of the staining patterns. In the first row, we have a mucinous ovarian carcinoma that has a strong 3+ staining. And in the second row, we have a mucinous borderline tumor with an intraepithelial carcinoma component that also has a strong 3+ membrane staining pattern. And in the third example, we have a mucinous borderline tumor only that has much lighter staining of a 2+ or HER2 score. So for this study, all of the mucinous ovarian carcinomas had a confluent invasive growth pattern, and there was only a total of 27 cases that were submitted for this study, of which 15 were mucinous borderline tumors. 7 of those had an intraepithelial carcinoma component, and the remaining 12 cases were mucinous ovarian carcinomas. So of note, the gastric and the endometrial serous carcinoma scoring protocols had the same outcomes because they both allow for basolateral and lateral membranous staining. HER2 cases that were negative with a score of 0 or +1 were also negative in any of the background lesions. And out of the 27 cases, 6 cases had staining heterogeneity, which was defined as a score of 2+. So table 1 is a summary of HER2 and FISH results that are stratified by intensity of HER2 staining and tumor type. The red boxes on this slide highlight the FISH results, and the data on this slide is the same information, just presented differently. But basically, any out of the 9 cases that had a HER2 score of +1, there was not any gene amplification. Out of the 4 cases that had a 3+ score, there was 100% amplification. And out of the 5 cases that had a 2+ score, otherwise known as heterogeneous staining, only 20% showed gene amplification in that category. This is the same table, but instead I'm highlighting the IHC results. And I put them here to make it easier to read. 25% of the mucinous ovarian carcinomas had a score of 3+. 14% of the mucinous borderline tumors had a score of 3+. 16% of the mucinous ovarian carcinomas had a score of 2+, and 28% of the mucinous borderline tumors had a score of 2+. So table 2 is a little bit more detailed in that it shows not only the HER2 and FISH results stratified by tumor type, but the pathological stage and the HER2 CEP ratios in a greater detail. All the cases that are bolded had some sort of gene amplification. And one of the trends that I wanted to highlight in this table is the fact that the higher in intensity that we go as far as HER2 staining, the higher the malignant potential of the neoplasm goes. So if you see here, like all of these 3 pluses correspond to a carcinoma, whereas some of the 1s and 2s are mostly benign lesions that may have an invasive component. The blue box here is one of the outliers for this data set, in which a mucinous ovarian carcinoma, where you would have expected to have a 3+ staining, only had a 2+ staining. And this case was reviewed several times for quality assurance, and it would be to be accurate. In table 3, this highlights, again, all cases that are bolded show a gene amplification, but it also highlights all the cases that had some type of heterogeneity staining. So in this context, it would be a tumor that has multiple components, but the HER2 score has like more than 1 score. So of note, we would expect all of the tumors with a carcinoma component to have a higher HER2 score, but some of them had heterogeneous staining. The authors did not give an explanation for this, but it's more of an observation that I thought was important. So in this paper, the findings from this study were concordant with prior scoring metrics in gastric and serous carcinoma scoring systems. About 25% of mucinous ovarian carcinomas had a 3+ HER2 overexpression, all of which were confirmed by FISH, and this is again consistent with the literature. And all +1 cases were not amplified by FISH, which is also consistent with the current literature in breast and in gastric cancer studies. And the authors emphasize heterogeneous staining within the cohort, which may suggest that the HER2 amplification occurs late in the progression of the tumors. So some of the challenges that I noted and that the authors noted in this paper was that over a 20-year period, only a small number of cases met the criteria. There was 27 cases, but I noted that the authors did not specifically state what the exclusions, what the exclusion criteria were. In addition, we know that mucinous ovarian carcinomas usually present early and have a low recurrence rate. Therefore, it's hard to compile the perfect study population that would consist of later stage tumors that would therefore be more clinically significant. We know now that different scoring protocols exist and are at the discretion of the pathologist which one they are more comfortable using. However, if you use a scoring protocol that has more strict criteria, you might rule out patients that are eligible inappropriately. And just as a nature of this type of study, when you have multiple pathologists reviewing cases, you're going to have a lot of inter-observer variation. And because of that, you will have a lot of subjectivity that exists between calling a borderline diagnosis between like not cancer or cancer. Some of the strengths of this paper was that it addressed a topic that has not been commonly investigated as of yet. The authors review whole slides and whole blocks instead of just referring back to the diagnosis line in the charts. They actually went back and reviewed the tissue. And Importantly, they proved that there was a positive correlation between strong HER2 expression and gene amplification. And they also noted that there isn't really a difference between the gastric and the endometrial serous carcinoma scoring protocols, and that they both provide similar results. And this is a good thing, because if you have a pathologist that isn't familiar with one of the scoring systems, it won't really change the outcome of their diagnosis. So for next steps that I thought were pertinent, we should try to create a standardized criteria that is validated specifically for mucinous ovarian carcinomas, instead of relying on the guidelines for gastric or endometrial serous tumors. Because of the rarity of this tumor, maybe participating in multi-institutional studies to help increase the sample size. And of note, this study only looked at primary sites of malignancy, but maybe we could include sites of metastasis or recurrence. This would be important because extra ovarian sites or recurrent tumors are more likely to be advanced stage, and therefore will need to have targeted therapies. And lastly, the overall utility and clinical implications of HER2 overexpression in ovarian mucinous tumors isn't fully understood. But based off of what the authors presented, maybe we could address the significance of the heterogeneity by tracking treatment outcomes and following up patients to see survival rates and how that corresponded to the pathological diagnosis. This is a list of my references, and thank you.
Okay, thank you, Stephany. And for our third speaker, I'll just ask Tariq if you can please share your screen.
Yes, sure. I think Stephany might still be sharing her screen.
Stephany, can you please unshare your screen?
Yes. Okay.
Thank you. Cool. Can you see my screen and hear me?
Yes. Thank you, Tariq. That's all great.
Great. So hi, everyone. My name's Tariq. I'm a third-year anatomical pathology trainee from Wellington, New Zealand. And I looked at this article titled Ovarian Endometrioid Carcinoma with a six-chord-like pattern, a morphological, immunohistochemical, and molecular analysis by Travaglino et al. From February 2024. So just a bit of background. So endometrioid carcinoma does display a significant amount of morphological heterogeneity. We know a subset of these can mimic six-chord stromal tumors, such as Sertoli Leydig cell tumors, or granulosa cell tumors morphologically. And these are termed six-chord-like endometrioid carcinomas, or SCLECs. These SCLECs may themselves show squamous, mucinous, or ciliated differentiation, such as conventional endometrioid carcinomas, and they may mimic a range of tumors, such as mesonephric-like carcinoma, female adnexal tumor, probable Wolffian origin, or FATWO, and the recently described STK11 tumor. So this study aimed to provide a sort of broad clinical, pathological, immunohistochemical, and molecular overview of these entities known as SCLECs. So they looked at all ovarian SCLECs diagnosed at their institution between January 2010 and December 2022, retrieved from a single digital database. Cases with available IHC molecular analyses were concluded, and these were reviewed by 5 gynecological pathologists from the same institution. 23 IHC markers were analyzed, which you can see there, using a range of biosystems. And in addition, they looked at 10 genes extracted using standard procedures. So they found 12 cases of SCLEC at their particular institution, As you can see from the pie graph there, 2 of the cases had no available material for histological review and were excluded from the final analysis. And an additional 1 case was diagnosed as stick-11 adnexal tumor on histological review, which we'll discuss a bit later. So finally, 9 cases were included in the study. The mean patient age was around 65 years old. 6 cases were limited to 1 ovary, while 3 cases had extra ovarian extension. So here we can see the sort of range of histological morphologies that were seen in these cases of SCLECs. Panel A and B show the Sertoli and solid trabecular architectures, that last one resembling granulosa cell tumor. And those 2 patterns were seen in 5 out of the 9 cases. C and D show the microfollicular patterns and squamoid areas. Squamoid areas were seen in 4 out of the 9 cases. Another morphological aspect that the authors looked at were what were termed eosinic cytoplasm and high-grade nuclear changes. We can see a range of these features here, from tumor cells resembling Hürthle cells in A, through to mucinous features in C and serous-like atypia in D. 4 out of the 9 cases showed these sort of morphological features. In terms of the IHC analysis, quite convincingly, all the cases examined were negative for sex-cord markers such as inhibin, calretinin, and SF1. All tumors were positive for EMA and ER and PR. A majority of the tumors were positive for CK7 and, interestingly, CD10 as well, which we'll discuss later in terms of the differential diagnosis with this entity. Only 1 case was positive for WT1. In terms of their molecular analysis, so all 9 cases were MMR proficient and POL-E wild type. 1 case, quite interestingly, showed aberrant p53 overexpression and was classified as p53 mutated. This case was actually shown to have a BRCA mutation, and according to the authors, high-grade serous carcinoma was, quote, considered but excluded, and we'll come to this in the discussion later. The remaining cases were classified as no specific molecular profile. The STIC11 gene was only tested in 2 tumors, which lacked endometrioid features histologically. And interestingly, 5 out of the 9 cases showed mutation in exon 3 of CTNNB1. So this roughly but not entirely correlates to 9 of the cases showing positive IHC nuclear beta-catenin. And all and only these cases showed those sort of eosinophilic cytoplasmic and nuclear pleomorphic changes. So summarizing those results, the histology of SCLEC showed a Sertoli and granulosa-like architecture, which is to be expected, frequencies of 2 out of 9 and 3 out of 9 cases, respectively. Important clinical factors are that SCLEC patients tended to be older versus the younger patients that tend to get Sertoli Leydig cell tumors. So this is a potential helpful demographic difference there. A minority of SCLEC cases showed overt endometrioid carcinoma features. So this represents an important diagnostic pitfall, as we may rely on these features to even consider that these might be endometrioid carcinomas. And IHC positivity for epithelial markers and negativity for the sex cord markers is very helpful in distinguishing SCLEC from its mimics, as was found in this study. So just going over some of the particular sort of differentials from this entity. So the distinction from female adnexal tumor of Wolffian origin or FATWO, the morphology of this entity shows a paratubal location and nodular architecture, which is multi-lobate with expansile borders and relatively bland nuclei, tubular to solid in architecture. These tumors are consistently EMA negative, unlike SCLEC. And while PAX8 negativity was thought to be helpful in differentiating it from endometrioid carcinoma, this study only showed that 3 cases of SCLEC showed PAX positivity. So actually the majority were also PAX negative. So EMA is the most helpful IHC here. The distinction from mesonephric-like carcinoma, again, this has a variable morphology, tubular to glandular to papillary to sex cord-like, and columnar to cuboidal cells. In particular, from the IHC point of view, CD positivity, again, was thought to traditionally help in this differential, but 7 out of 9 cases of SCLEC also showed this. However, helpfully, GATA3 positivity and TTF1 positivity in this entity as a helpful distinguishing IHC, as well as ER and PR negativity, which were convincingly positive in SCLEC. And finally, the distinction from this sort of newer entity called STIC11 adnexal tumor, which also has a mixed architecture within a single tumor with a prominent myxoid stroma and cuboidal to spindle cells. These tumors are convincingly WT1 positive and inhibin calretinin positive, which is completely the opposite in the SCLEC. They may also show focal CK7 and CD10 positivity, and ER and PR is positive in this entity, which overlaps with the SCLEC. So there are some important limitations of this study. First of all, there was a very small sample size, so only 9 cases, which might be expected in a single institution study of a rare entity. So this might not be representative of the full range of this entity. Also going with that, so this was a single institution study, and it might not capture the full range of all sex cord-like endometrioid carcinomas, and it may only focus on a certain population group, for example. There was also no mention of blinding, and because the pathologists that were reviewing these cases also worked at the institution from which the cases came from, they may be biased by the original diagnosis, might not have questioned if these were in fact endometrioid carcinomas, and maybe assumed some factors to be correct and not questioned them. Intra-observer variability between the 5 reviewing gynae pathologists was not mentioned, and there was no mention about any variance between the pathologists, which would be important to know, especially when commenting about morphological features, for example. There was also a limited number of tested genes, and these were not tested uniformly across all samples. So for example, only 2 cases had STIC11 gene mutations tested based on morphology, and this perhaps raises the possibility of more cases could have been reclassified if genetic and molecular analyses were applied uniformly across all the cases. Follow-up data or treatment was not mentioned, so it would be interesting to know whether sex cord-like endometrioid carcinomas behave like other endometrioid carcinomas, or do they behave in a way that's closer to sex cord stromal tumors? We don't have that information, and it would be useful to know. In particular about this, that one case that was P53 mutated also had focal inhibin staining and a much higher Ki67 than the other cases, which is quite different. So it's possible that this case might actually not represent a case of sex cord-like endometrioid carcinoma and is better classified as perhaps a different variant or perhaps even a different tumor altogether. Finally, the lead author does reference himself quite a bit in this study, and this self-referencing might lead to confirmation bias in terms of the cases he's reviewing, as well as the sort of expected outcomes from the analysis. So in summary, sex cord-like endometrioid carcinomas is an uncommon variant of endometrioid carcinoma. This study showed that it's got a consistent IHC profile, which is sex cord marker negative and positive for CK7, EMA, and ER/PR. Molecular analysis showed that most cases have a non-specific molecular profile. However, there are some variations in IHC and molecular profile that might be worth exploring in further research. there are important limitations of this study when applying the results, and it's important to keep these in mind when thinking about this entity and its differential diagnoses. And that's the end of my presentation. So thank you very much.
Thank you, Tariq. So that's our third presentation done. So I'll ask all our speakers and my fellow panelists just to turn on their cameras. And we're just going to briefly discuss some of these papers. Now, Brooke, I mentioned there was a question in chat for you about the P53 paper. Now, it's a two-parter, so I will read this out. So it's a little bit of a detailed question. Is there robust evidence that TP53 correlates with tumor biology and prognostic outcome? And the second part, is the paper advocating that we base the distinction between mucinous borderline tumor and mucinous carcinoma on the presence or absence of P53 abnormality? So a rather chunky question.
No, but an excellent question. So regarding the first part about tumor biology and prognostic outcome, the only feature that this paper looked at that could have gotten to that was death by disease. And by that parameter, there was no significant difference according to TP53 status. So this paper, like the others that the question asker alludes to, does not show a relationship between TP53 and prognosis in this type of disease. And then for the second part, is the paper advocating that we base the distinction between MBT and MC on the presence or absence of P53? I don't think, based on my reading of the paper, that the authors go so far. I think that they suggest that it could be used in cases where there is ambiguity and you just need that one thing that could flip the balance towards one side or the other, but it is not the thing, the crux that you should rely on to make your diagnosis.
So Brooke, just a follow-up question. I found it a little curious in your paper, that the scorers, the pathologists were given the P53 result rather than the P53 slides to look at and make their own judgment about whether or not the P53 was abnormal or not. And as you allude to, it's not straightforward and easy. What do you think? Do you think this paper might have a different outcome if you asked the scorers who were looking at the tumours to also score the P53 to come up with their own interpretation? Would that add another layer of complexity, or?
I think it would add another layer of complexity. That's perhaps something that they were attempting to avoid by giving the predetermined scores up front to the pathologists. Many other papers have alluded to how poorly we pathologists agree when it comes to quantifying stains. So yes, that would absolutely contribute to another layer of potential disagreement.
But do you think it would maybe reflect real life more accurately?
Yes, I think it would. And my point about including more pathologist readers and more cases in more institutions, I think in order to kind of suss out the impact of that, yes, a greater N would be required.
I have a question really for all of our speakers. As is common when we assign papers, it is a bit like going down a rabbit hole and it can feel very esoteric. But I suppose for each of our speakers, I would ask, once you've read your paper and you've digested what you've taken away from it, how would that change? Would it change how you approach one of your particular assigned lesions next time it comes across your bench? So maybe starting with Tariq. So next time you see something that looks like a sex cord-like endometrioid adenocarcinoma, has reading that paper firstly changed the way you might look at it, and what other problems might you find?
Yeah, I mean, a rare tumor, so I haven't yet come across it. But I think the paper really highlighted that, how do we actually know what a particular, sort of tumor behaves like and is going to stain with? Because, this was quite a limited analysis, but to some extent, it's almost like as is the case with some of these rare entities, it's like a statistical exercise almost. How many are going to be staining positively with sort of this marker or have this genetic subtype? I think this study would just make me sort of pause and consider differentials much more widely than I would have previously, in a way, and sort of just keep that open mind when seeing, for example, a tumor with this sort of pattern that might overlap with many different entities, some of which are newer, such as the stick-11 adnexal tumor. I would not have considered that as part of my differential before because I didn't know it existed. But I think just having that open mind and realizing that just because something maybe looks a particular way, that the IHC molecular analyses, you have to sort of put all of that together to get to that final diagnosis. So yeah, just being sort of a bit more nuanced in what is considered in terms of the differential.
Tariq, so once you've decided, say, your sex cord-like lesion is actually an endometrioid adenocarcinoma, did they give you any more advice about, say, grading unusual architectures like this?
So this paper didn't, and that's another really important point in terms of the limitations is how would you grade an endometrioid carcinoma that has a sex cord-like pattern? I mean, as I showed in terms of the morphological patterns, some of those features could be interpreted as sort of a solid pattern. Would that come into sort of FIGO grading when you're determining a grade, or is it, or do they behave as sort of that more low grade, no specific molecular profile type, in which case you may have to, in a way, disregard the solid nature of those sort of sex cord-like features. They didn't talk about that. So again, it would be useful to know the outcomes of these tumors, whether they do in fact behave like endometrioid carcinomas or perhaps somewhere in between endometrioid and sex cord stromal tumors. And I think in practice, the best we can do is maybe relay in our reports to the clinicians that sort of uncertainty and try to explain that, you know, this might be a pattern we don't normally see, best regarded as X, but you know, that there's some uncertainty around that. So conveying that is a tricky thing, but maybe something worth doing.
Thank you. So Stephany, I suppose over to you. When next time you have a large mucinous borderline tumor / possible mucinous carcinoma crossing your desk and you're asked about HER2 staining, what are you going to do?
I think this answer is dependent on the institution that you work at, as far as like the lab protocol, in addition to what the OB-GYNs are looking for, I suppose. I would want more clinical information about the patient to know, is this like the first time that they're having this tumor? Like, what are the expectations of the surgeons? And if I haven't encountered this here, but if my lab, if it's, I guess, like within the budget to like use this staining for this particular tumor, that's a big consideration, because I know that if certain tumors aren't approved for certain therapies and can't have, like the patient will have to pay out of pocket for that testing, things like that. So I would want to check all of those things and take everything into consideration. But ultimately, based off of this paper, I think that it would be worth it to try to distinguish, like, if there's alternate therapy options that you can use, even if it's kind of experimental in like early stages.
As you mentioned, the access to alternative targeted therapies would be really important in this context, and if your patient may have that opportunity or not, which also raises the stakes for you as well, I suppose. So I suppose, what's your feeling for the heterogeneity that people talk about in staining? How far should you chase that sort of little bit of 3+ staining that could get a patient across the line, do you think?
So I kind of wrestled with that while I was going through this paper. I guess based off of reading similar papers on this topic, specifically the paper by Kang et al. That was presented earlier, and another one by Dunder that talks about P53 staining. If I'm not sure if I have mucinous, ovarian carcinoma, or NBT, would it be okay for me to use P53 staining to try to hash that out, as well as getting consensus from my colleagues? I think that since we know that this is a small group, it can't hurt to go to, to try to chase the answer down, I guess. I think it would be more important to be able to treat the patient appropriately. So I would want to try and find the best answer.
Okay, thank you. And so, Brooke, I suppose coming back to you, we're at the sampling question again, and as you said, I think you used the term one good block. Which block is it, do you think? And again, I suppose from a practical point of view, how hard would you chase that?
Right. My experience has been that we attempt to select the block with the most viable tumor cells in number, as we tend to use the same block for our immunohistochemical stains and molecular, and that obviously helps our molecular folks out. And yet we do find that when we stain multiple blocks, sometimes there is a focus of TP53 abnormality that is not reflected in our original stain block, and then we kind of throw our hands in the air and wonder what to do about that. I don't think that in clinical practice it is worth staining all of your tumor blocks in order to find a focus of subclonal abnormal TP53. For these mucinous tumors, that becomes a great challenge because there is incredible heterogeneity and often a ton of blocks to choose from. I think the fact that they did stain only one block, to me, I read that as actually practically helpful, since that is what we do in practice. So that makes their results most translatable to what I would do with my single stain slide from an entire case with its just one slide worth of P53 results. So I guess, at least just based on this paper's results, I would not go chasing after staining additional blocks.
Thank you. So I'll just ask my fellow moderators if they have any further questions for our speakers. In which case,
I've got a question. I'm interested to know who's doing P53 on mucinous borderline tumours routinely. Is it something that's being done at Stanford?
Routinely, to my knowledge, no.
Okay, so it's not yet something that's been embraced in practice. I know of one centre in Melbourne that the clinicians have asked the pathologists to do it, based on the studies that are out there, but I don't know how it's impacting diagnostically and in terms of treatment. I was just curious if anyone has taken it up yet. It sounds like it's a no.
What about the same question for her too? Because we're being asked to do it here now in mucinous.
Oh, wow.
We're doing her too.
Yeah, same here. I think it's a very ad hoc for us as well, for her too. They just, if they want it, they'll ask us for it.
Okay, well, if I have no further questions, and all that's left for me to do is to thank our three speakers. So thank you, Brooke, Tariq, and Stephany. Journal Club will come to you next month in August from the other hemisphere, so tune in for that. Thank you to my fellow moderators, and thank you for joining us.
Thank you.
Thank you.